today's session. It's my pleasure again to be the chairperson for this session. It's another endoscopy session, and it's got a lively sort of theme to it, and it will be very interactive. It's obviously this is our G-Echo, hosted by the GastroFoundation and New Mexico Echo and the GastroFoundation. And this is our weekly Wednesday slot. Again, next week it will be pathology, but we welcome you every Wednesday. And we'd like you to know that there are 57 registrants from approximately 22 countries. So we've got good representation on the registration. We just hope the participants pick up and that the registrations turn into actual participation in this. So without further ado, Dr. Chinnery is a surgical gastroenterologist with an interest in interventional endoscopy. In fact, she's an expert in it. And it's over to her because she's going to show you a potpourri of things that you can find in the gastrointestinal tract. But not only that, how to deal with them and manage them. So over to you, Galia. Please share your screen, and I'll mute and go silent.
Thanks, Prof. So welcome, everyone. Thank you for the invitation. We are going to have a fairly, can you see it? Sorry?
Yes, it's coming up.
Okay, perfect. We're going to have a fairly relaxed session today, so no hard theory or anything like that. What today is about is essentially I'm going to be showing you a couple of videos that are not perfect. They are exactly as we have experienced them. They are taken from our endoscopy suite on a scope list when we're doing a list, which we hope to show you something specific. I've got some random questions to ask about them, and basically it's just to test yourself. And yeah, I appreciate that the beautiful endoscopy pictures that you see in endoscopy atlases don't always realistically show what it's like. So let's get going. So the first case is you are busy scoping a patient that you know and has an esophageal malignancy, and you start your scope off, and this is what you see. Right, hope you saw that. And this is my question. Which of those cords is paralyzed, left or right? If you can just participate in the poll, that'll be nice. We'll give it a few seconds, and then once people have put down their answers, we'll move on. Why am I asking this, and why should you be looking with every esophageal malignancy? Well, quite obviously, if the tumor has infiltrated the recurrent laryngeal nerve and has paralyzed one of your cords, you know that lesion is a malignancy that's beyond a T4 stage and is locally advanced, and as such, what's the word? Gosh, I'm going blank. Not an operative candidate. So in an environment where you are very short on CT time, you can argue that this is a patient that doesn't need a CT. You already know there's advanced disease. But yeah, so that's why we always look at the cords when you do your scopes for malignancy.
Can I end the poll?
Yes.
Sharing the results.
Okay, so 2/3 of you said left, the other said right. Remember, due to the inversion and the fact that you're upside down, your scope at looking at your larynx is exactly the same. So right equals right, left equals left. So it's actually a bit of a trick question. If the right looks paralyzed, it is actually the right one. Okay, so good. Next question. You're busy scoping a patient who's come to you for an urgent scope, HB of 5, a witnessed upper GI bleed. And as you go down, you notice a fresh clot on what you suspect to be a duodenal ulcer. There's no active bleeding at the moment. Your patient is stable. What is your plan? I've given you 4 options there. Cheryl will launch the poll, and then you can just choose, in theory, with that situation, what would you like to do? So either just give IV PPIs, patient is stable, there's no bleeding, or give IV PPIs, try and remove the clot, and then deal with whatever's underneath. Give PPIs and refer immediately to the surgeon on call, or IV PPIs and refer for an angiogram and embolization. I'm hoping you're all going to answer the same one. Let's see. I'll leave it up to you, Cheryl, when you want to share.
Okay. I'll give it another few seconds.
Okay.
Okay, I'm going to end the poll,
Okay.
share the results.
Good. Okay, my heart is happy. Most of you said to remove the clot and deal with whatever's underneath. So that takes a bit of, yeah, you need to be happy with dealing with bleeding ulcers. If you're not, then don't remove the clot. Wait for someone who's around to come and give you a hand, but you have to deal with a fresh clot. Just admiring it from a distance is not good. So I'm going to show you what we did. So this is that situation. Nice, juicy, fresh clot peeping through the pylorus. And you get a pretty good idea that that's where your ulcer is sitting, D1 somewhere. So we've pulled off the clot. And I look at the ulcer base, cleaning it up a bit. It's a bit of suction. And I hope you can see and appreciate, well, there's the problem. Can you see, I hope, that it's pulsating? Okay. In this situation, I think there's a couple of options. What we chose to do, because it was quite a large fibrotic base, we have the luxury of over-the-scope clips, which I think work fantastically when you've got a very big fibrotic base. Scratching around with hemoclips isn't going to work here. I think the only other option might have been a gold probe. But look what happens when you apply the suction to that artery. Boom. So you really got to make sure with that firing you got the right position. So there you go. Avesco nicely in place. I think that was a good thing to do. So here's the question now. Again, same ulcer with that horrible, scary, visible pulsating artery, but you do not have Avesco clips available. So what would you try? Let's launch the poll. I've sort of given it away, but let's try and see what you would think. Maybe there's another option I didn't think of. Okay, so either all options include injection, and remember your injection is to create a tamponade. It doesn't stop the bleeding. That tamponade is not for long. It's quite temporary. You need to do something else. So either gold probe or hemoclips for this specific ulcer. What would you have done? If you can share the poll when you're ready. The answers.
Okay, I'm ending the poll. Sharing results.
Okay, so I think, yeah, again, 2/3 of you I would agree with, inject and gold probe. I'm going to tell you, in my experience, I think this would be a bad idea to apply hemoclips, in that you will just scratch around that artery. You will not have enough soft tissue to be able to close and clip anything nicely or effectively there. I wouldn't waste my time with hemoclips. I think you're going to make a mess. So I would have gone with a gold probe if I hadn't had an Avesco. Okay. So next one is a patient that's on your routine list, and you are scoping this patient for a chronic cough. and a right lung abscess. I'm going to show you the endoscopy little video. Okay, so that's the most important view. And the question is, so now that you've scoped this patient, you've seen a large tracheoesophageal fistula and you're peeping straight at the carina. What is your management option in this situation? And you can share the poll. You can either decide to put in a peg, you can manage this conservatively, you can place a covered esophageal stent, or you can refer to surgery. Let's see what you feel like doing. Okay, shall we share the poll results? Okay, so a couple of you said peg, and the majority of you were thinking to pop in an esophageal stent, and then whoever voted for surgery, I'm on the same page as you there. I think you have to appreciate the problem with an esophageal stent in this situation is it's not going to stay in place at all. There's no stricture. You flew down that esophagus. That stent will have moved by the time the patient is back in the ward. You would need to find a way to keep that stent in place. You can use a Novesco clip potentially. Hemo clips don't work. The mucosa just falls off after a while, so that doesn't work. So I think a stent is not an option. This is such a big fistula. You can't even close it endoscopically in any way that I can think of. What you would need to do is to send to surgery, and they would need to divert that esophagus somehow, which is obviously quite a big deal. But this unfortunately needs surgery. A peg here is not going to help you much either. Right. Okay.
Can I ask a question, Gally?
Yes, please.
So obviously we're not quite sure what the pathology is here. You didn't tell us what the pathology is.
No.
Do you have a tissue diagnosis?
It was TB.
It was tuberculosis.
Yeah.
Yeah, that's interesting. Again, every so often one of these things comes up, and we always attribute it to a cancer in either the esophagus or the bronchus. But perhaps you could enlighten us, if it was smaller and related to a cancer, what's the sort of cutoff size for thinking that a stent wouldn't work? Obviously, this is very high as well. So
I think, yeah. So I don't. To me, so stenting and malignancy, tracheoesophageal malignant let me start again. Stenting with malignant strictures for tracheoesophageal fistula always works well, in that you've already got a stricture there to keep your stent in place, and we routinely use stents in that situation, and it works jolly well. It really does. They're usually quite small, these little fistulae in a malignant setting, and are covered up quite nicely. The height of placement of your esophageal stent is tricky if it's a benign situation. If it's a malignant situation and the tumor is quite high, these patients already have, coming through your front door, a globus sensation. And it's remarkable how well they tolerate very high strictures. It's very high stenting. And it's not infrequent that we stent patients where the top flange is actually just beneath the cricopharyngeus. It's amazing. Every now and then we have to pull it out in the recovery room. It's they're not coping, but the majority actually do quite well. So it's quite often that we stent very high. I hope that answers your question.
Yeah, just one other aspect. Sorry, it's when, I mean, obviously you can get a cancer in the bronchus or from that. When that happens, I must admit, I don't know much about it, but what's the role of bronchial stenting in that situation? Or is that something you've embarked upon with the cardiothoracic people?
Yeah, they're very unkeen to do it. Doesn't work well. They block very quickly, and they have a tendency to migrate, which you can imagine a disaster if it migrates down a bronchus. So in this situation, the few cases that we've dealt with, we've actually physically gone and done a surgical diversion of that, where you proximally and distally tie off the esophagus, leave that little stump there, and that becomes the new sort of back wall to that fistula, to that trachea. It's not a permanently beautiful option, but it's something that gets the patient home. So we've done that a couple of times. It's a big outing.
Yes.
But
Thank you very much.
Cool.
That's good.
Okay. Right. Maybe I forgot. Okay, so what do you see on scope at this next video, and what are you expecting the cause to be? So let's show you the video first, and then I'll give you the options. So that's sort of mid to distal esophagus. Okay, so if you can put the poll up, what do you think this is? My options that I'm giving you: caustic ingestion with a grade B injury. And the second option is grade D reflux esophagitis, perhaps with a large hernia below that. C, grade D reflux esophagitis related to gastric outlet obstruction. Or D, caustic ingestion with a grade C injury, and you should refer to your surgeons for esophagectomy. Okay, are you ready to show us the poll, Cheryl?
Yeah, will do.
Okay, so I didn't give you a history, so it was a little bit unfair. But half of you are thinking this may well be a caustic ingestion, grade B, and you'd manage conservatively. I agree, it looks like a grade B if this were a caustic. But I think this is quite clear to us. We see this horrible reflux grade D esophagitis related to stasis from gastric outlet obstruction. And it's classically this intense cobblestone, almost the entire esophagus looks like this, and we always see it with a goo. So if I go down the esophagus and I see this, I know, one, to have my suction ready, because that gastric fluid is going to come up at me. And two, I know there's almost 100% chance of a gastric outlet obstruction. I think with a large hiatus hernia, yes, you can get grade D reflux, but I think you almost need a new term for this type of reflux. We write it in our notes as stasis reflux, because it's just so impressive. But yeah, you can imagine how miserable this poor patient is. Okay. Here you scope a routine young lady for dyspepsia. I'm going to show you the video quickly. And you go down towards the antrum, and this is what you see. Okay, hope you saw that. And my questions are, what are you actually seeing there? What is that? Is it a small gastric cyst? Is it perhaps an adenomatous polyp? Is it a pancreatic remnant? Or with that yellow tinge, is it maybe a gastric lipoma? Do you want to launch the poll for us? Thank you. I think it's quite important to know what this is. You do see it every now and then. In theory, 1 in 1,000 patients has this. I'm not sure if it's that common on everybody's scope list. Let's see the results of that poll. Yes, thank you. So this is a pancreatic remnant. It's got that classic little umbilication. It's also in quite a classic position. That's gastric, that greater curvature in the antrum is where they like to sit. Do you need to do anything about it? Absolutely not. You can admire it, call someone to see, but don't need to biopsy it or anything. Leave it alone. Right, now the next one, you are scoping a 51-year-old gentleman for odynophagia. And here we have the scope coming down proximally. Good. Okay, so here are my options. Either candidiasis with an idiopathic esophageal ulcer, candidiasis with a malignant distal esophageal ulcer, or candidiasis with a CMV ulcer. Cheryl can put the poll up for you. You can decide what you think that distal ulceration was due to. I hope you all get this one. That's pretty classic. Okay, let's see, Cheryl. Yes, good. So most of you agree that's very likely to be a CMV ulcer. They almost look stapled out, punched out is perhaps a better word. Very smooth cut out edges, like you've gone and cookie cutted out a piece of the mucosa. And in this one, you actually quite, with some imagination, you could see the sort of circular indentations of the circular layer of esophageal muscle. So this was CMV. You biopsy the edge of that ulcer to get your pathologist to assist you. And then the clue was obviously the candida proximally in a patient with some immunocompromised issues. So yes, CMV ulcer, good. Okay. Now you are Scope, who is early 60s, and the history is significant loss of weight as well as dysphagia. And the patient reports tolerating only a soft liquid diet. Now let's take a look at the scope. Okay, so there you have it. Rather large, nasty looking in the mid esophagus. So I'm going to tell you it's malignant, and that give me a decision as to you think might be histology. So you can put the poll up, but options are an adeno-CA of the esophagus, a squame, or a GIST, or melanoma. Let's put the poll up. Okay, I hope that was enough time. Let's see what you thought. Okay, so let's go through those individually. I think, yes, you might be correct in thinking this is an adeno. It is fungating, unhappy looking tissue there. A squame is probably quite likely to obviously get mutative versions, but every now and then you do get this. I find the squames are, yeah, they really not they can be obviously, but they're really so defined on, they seem to be, they grow circumferentially very quickly. I find the adenos are the ones that usually are more one-sided, if I can put it that way. A GIST, yes, I think it can be. And this is a sneaky one, melanoma, that's the answer. I see some of you saw the clue. At 6 o'clock, there was a big black spot in the mucosa. So this is an unusual presentation of an esophageal malignant melanoma. Interesting case. Good pickup for those of you that chose D. Okay, now you are asked by a colleague to repeat a scope for a lady of 30 who's been previously well. She's been complaining of persistent vomiting and loss of weight, and they have scoped her last week, less than a week ago, and you're a little bit irritated that the patient's coming back to you. But they definitively said there was no obstruction, but the patient's continuing to vomit. So you scope the patient. And this is what you see. Okay, OG junction into the stomach. And here's the pylorus, and quite clearly you agree with your previous previous colleague's assessment. There's obviously no pyloric distal obstruction. But what do you think? Oopsie. So here we go. What is your diagnosis? Yes, you agree with your scope, your previous assessment by somebody else, normal scope. Or B, this is potential plastica, or severe pangastritis, or bile reflux, or you think there's an element of antral extrinsic compression. Why don't you put the poll up for us? Thank you. Okay, let's see. Yes, okay. Thank you to everybody who answered B. This is Linitis plastica. So the first thing you should have noticed as you went down, a couple of things. One, there's a puddle of bile or gastric content that shouldn't be there on an empty stomach. So there is an element of a functional outlet obstruction at least. Then your antrum, your distal body and antrum were quite compressed. You didn't get a nice expansion with insufflation at all, and the impression was quite clear to me that mucosa, thick and hard, and biopsies, random biopsies of that mucosa did come back as an adeno. On CT scan, a very thick concentric distal body and antrum in keeping with Linitis plastica. So just again don't ignore persistent symptoms. The patient isn't always just making funny symptoms up out of their head. There is sometimes a problem where a previous scope has been reported normal. So I think a second opinion isn't always a bad thing. But yes, thank you for picking that up. Then number 10, you are asked to take over a scope from a younger colleague who's been really struggling to scope this specific patient, and the complaints are early satiety with epigastric pain. Much to your embarrassment, you did want to look slick and impressive, but you too struggle considerably to reach the pylorus. So let me take you through this rather painful scope. So this still looks all right, flying down the esophagus, a bit of saliva bobbing around. Probably OG junction there, Z line. I'll have you know we edited this video. By this time we were sweating. You're trying to look slick and you just can't get to that jolly pylorus. Retroflexing like crazy.
Has the patient had any surgery?
No, nothing. First time scope. Okay. Eventually you give up. No pylorus to be seen. So after your embarrassment is over, what do you think is the diagnosis and which investigation will you ask for first? So you can pop the poll up there for us, Cheryl. So I'm going to give you 4 options. Is it either a type 3 hiatus hernia and you want a CT scan? Is it a type 3 with a gastric volvulus? Do you want a barium swallow? Type 4 CT scan? Or do you want a type 4 as your diagnosis and you want a barium swallow meal? Sneaky question. Okay, Cheryl, do we have some answers? Yes, great. So you cannot diagnose, first of all, a type 4 hiatus hernia endoscopically. You cannot see if there's any small bowel, colon, whatever slipping up beside it. So you can't say it's a type 4. It's a type 3. And your options are either CT or a barium swallow. And I would agree with the majority of you that I would have also gone for a barium swallow meal because I think that fluoroscopy gives you a much better impression of a volvulus. It's much easier to appreciate, also to see the degree thereof, and very importantly, to determine where your OG junction is in relationship to your diaphragm, in that you do need to repair this probably, and it's pretty nice to know before that time whether you have a shortened esophagus or not. So I would go with B. I think it's definitely a type 3 hernia, at least, with a gastric volvulus, because you just couldn't get to the pylorus. And I would have gone with a barium as well. Good. Okay, so oncology refers this patient to your intervention list, and the history is that it's a metastatic gastric cancer with clinical features of gastric outlet obstruction, and they're asking you to pop in a stent. What is your treatment plan after you see the scope? Okay. So what do you think you should do? Your options are either to pop in a stent, to offer palliative chemoradiation, because you already know this is an adeno and it's metastatic, or you're going to put in a PEG. Okay, thank you, Cheryl. Okay, so a few of you opted for a stent, some for PEG, and half of you for palliative chemoradiation. I'm going to go with the palliative chemoradiation as well. I think here you really have to appreciate that it's a functional gastric outlet obstruction. Essentially, you've got a mid gastric body tumor. It's not obstructing, but the pure fact that it's sitting there and is probably within the muscular layers becoming concentric means that you've got this functional obstruction, if I can put it that way. But the issue with stenting these things in the mid body, they do not hold very well at all. I think we've given up trying. I think the only time it really makes any sense to do it is if it's a pinpoint opening that's left. And then you have to appreciate that all you're doing is draining the proximal stomach into the distal stomach. It's really a poor functional outcome with an endoscopic stent. And I would only do it if it's very tight. because otherwise the stent is going to fall out within the first cough the patient has. So I wouldn't stent this patient now at all. It's too early and it's not going to work. It's a really awful situation to be in. The best would have been surgery, but if it's mets all over the place, it's really a horrible end. A PEG, I would definitely not consider. I think the concerns are where you're going to put it. First of all, you would have to put it in the antrum. To put a PEG in the antrum safely with malignant cells bobbing around, I think you're going to spread that thing even more and potentially create a really nasty PEG fistula. I don't think that's fair at all. So I wouldn't offer a PEG. I would have gone with option B. Okay, so you are now scoping a patient that's had an...
Sorry to interrupt. Is it possible to ask a question on that case?
Yes.
Sorry to interrupt, Galia.
That's fine.
So this sounds like quite advanced disease, metastatic, and as you're saying, there's no mechanical obstruction. My question is, what is the outcome with chemotherapy at this stage, and whether one shouldn't rather consider just keeping the patient comfortable, pain management, feeding, etc. So I'm just wondering to what end would the chemoradiation serve in somebody where this seems quite advanced? It's just ignorance. I don't know the answer. Thanks.
No, I don't think it's ignorance at all. It's a difficult clinical situation. I think you're absolutely right. Your option D should have been supportive care and involving the palliative care team. 100% agree. You know, the radiation in palliative gastric CAs we reserve for specific situations where there is continuous significant bleeding requiring transfusions, and you're unable to operate the patient. So then we would offer palliative radiation for the stomach. In this situation, I agree with you. You're not going to win. It's a really horrible way to go. Ideally, I think if it's not, wrapped around the pancreas or something like that, this is a scenario where you might consider a palliative gastrectomy. But again, I think the patient has to be very much aware of the considerably higher risks for that anastomosis in this situation. And really, that should be a case-by-case decision. I think the majority of these patients end up with supportive care. It's a horrible way to go. You can't eat properly. You're vomiting the whole time. You're nauseous all the time. It's not a good way to go. And you really can't help much with a stent. So yeah, I agree with you. Supportive care probably. Yeah.
Thanks, Galia. Thanks.
Can I just add?
Hello. Yes.
May I add just something there? I think that the other thing is that some people really believe that you should offer nutritional support to these individuals. Obviously here the stomach really isn't available because you're not going to put a peg in through the tumor. And then again, it becomes very much an ethical question as to whether or not you should give them supportive nutritional support. For instance, in the United States, an individual like this might well get a jejunostomy. I don't really want to prolong the debate on it, but I think the nutritional support side of it is a double-edged weapon in patients who have probably less than a month or maybe 2 months to live.
Yeah, so I agree. It's always a difficult decision. The issue with the surgical, so I wouldn't do, so how are you going to put in a jej? You're either going to put in a nasojej, and then your patient is already vomiting and gagging at the best of times, and now they've got a tube down. How long your tube stays in place, I'm not sure with all that. Then your option is a surgical jejunostomy. I didn't specify whether this was peritoneal disease or whether it was just lung and liver mets. I think, as you know, a huge majority of our gastric CAs present towards the end with peritoneal disease. And then to go and do a laparotomy and pop in a peg and a jejunostomy, also not a wise thing. Specifically, as you say, you don't have very much time left. So I think, yeah, and parenteral nutrition, yeah, that's another step. Yeah, I don't have an answer here, but I wouldn't do anything invasive here. I think you would regret that. Tricky one.
Thanks very much, Kelly. Carry on.
Okay. You scope a patient now with an upper GI bleed and you admire this beautiful ulcer. I want you to look at the ulcer and then I want you to tell me what you think was the cause. Okay, so ugly ulcer, quite large on the intersural distal antrum kind of surface. What do you think? Is it malignant? Is it an enzyme-induced ulcer? Or is it an antral caustic injury? Okay, let's see the answers. Okay, so it was an enzyme-induced ulcer. Yes, I would agree that there are certain concerns with this ulcer. You might be right with a malignant concern, but the ulcer edges were quite punched out and quite a specific positioning for little old ladies that gorge themselves on grandpas. This is where their ulcers usually sit. So this was an NSAID-induced ulcer. Caustics don't generally, when they get ulcers, it's usually sort of a week to 2 weeks later that they come for their scope. And you see an ulcer with quite a sloughy base, very sloughy, and sometimes almost an Escher type of appearance to it. So this to me wouldn't have been a typical caustic injury. Okay, this is just for fun. You remove a foreign body embedded into the proximal esophageal wall. Which animal bone is the most likely culprit? So I'm going to show you what it looked like. So there you are, proximal esophagus, something poking there. Quite sharp and horribly stuck. And I think what we used here was actually a stent grabber, which has got a very nice, almost shark-like bite to it that we normally use to reposition stents with. But it grabbed this piece of bone quite nicely. And then we slowly wiggled it out. I think with any foreign body removals, it's absolutely essential that you sedate the patient. You don't want them coughing and spluttering while you pull something sharp out. And depending what it is, you might even consider using a rigid esophagoscope. So there's the bit that we pulled out. So my question to you is, what is it? Chicken, lamb, beef, or snook? Take a wild guess. And the reason behind the question is what I think it depends where you live, obviously, but we see one specific bone more often than the others. Let's see, Cheryl, what people said. Snook. Yeah, I think that's pretty valid guess if you're sitting in the Western Cape, for sure. Nobody chose beef. Yeah, I've never seen a beef one either. That's what it was, lamb. The biggest culprits as regards food, what we see bone-wise, is always a lamb bone. Don't know why. Okay, you scope a lady with a chronic iron deficiency anemia. What do you see here as the cause? Here's the scope. And you're retroflexing. You see quite an impressive hernia. And my question is, or my answers are that you can choose gastritis with erosions and a sliding hiatus hernia, a watermelon stomach with a sliding hernia, or Cameron's lesions with a sliding hernia. I hope that you answer this one really quickly. Let's see, Cheryl. Yes, thank you. So C, Cameron's ulcers or lesions, whatever you want to call them, with the sliding hernia. Remember, they are due to friction, the combination of friction and gastric pH that on the where the crural indentation is on the hernia. That's where you get these ulcers. You will notice though that they're always a bit lower down once you do your scope, and that's got to do with your insufflation. So your insufflation artificially changes the position, so you might miss them. So you should actually be aware that, I hope you saw them on this, that they were a bit lower down than the indentation of the actual hernia on the diaphragm. Okay, what investigation do you want after you have seen this duodenum? Let's take a look. We're in the duodenum now already. That was pylorus. That's D1. And there you go, D2. Okay, so what investigation would you like? A CT, a colo, an EUS duodenum, or a spiral enteroscopy? Okay, let's see, Cheryl. This one should be easy. Yes, great. So you definitely want to start off with the colonoscopy. With this kind of presentation, the duodenum, you need to consider an FAP patient as a possibility here. And I would start with this colonoscopy as well. Good. Okay, so now I'm going to show you an esophagus or with some varices. And the question to you is, should you do the banding? Should you not do any banding? Or are you going to be kind and let your new registrar in your firm, who is super keen to band this one? Okay, so give me an answer. Are you going to do it, or you are happy to let your registrar have a go and you're going to teach them how to do it? Okay, let's see. Okay, you're going to do it. Good. The only person who's going to let someone do it is Prof. Thompson. I would say you should do this one. In that, I hope you noticed, sort of at 3-4 o'clock distally, there was some slough. This is definitely a varix that is recently bled, and you do not want some slightly more inexperienced person applying some suction to that and then letting go by accident. That's going to be an absolute bloodbath. So this is a varix somebody should do with previous experience. I agree. I would do this one myself too. Okay, you rescope a patient with a previous diagnosis of a severe pangastritis. She remains super symptomatic after eradication, and she promises she's taken it. She's also been on a month of PPIs. She is an insulin-dependent diabetic. And I'm going to ask you, do you agree with the previous endoscopist diagnosis of severe gastritis? Let me show you the video. little bit sticky to get through the OG junction. And then you're in the stomach. And a little bit of a squish to get through into the duodenum. Okay, so do you agree, first of all? That's just for you to decide, but what is your plan? You want to offer second line eradication, you can pop up the poll, thank you. And make sure that you increase to BD PPIs. You want to increase the BD, to BD and stop and hopefully ask the patient to stop smoking. You want to take biopsies and do a CT abdomen, or last option, you would like to do a barium meal and exclude a functional goo related to her diabetes. Okay, let's see what you think. Yes, thank you. So this is Linitis plastica again. And I'm just putting another one in there just to show you how easily they are missed by ourselves. And what the clue was here is that, yes, there was no obvious obstruction, but I'm sure you'll agree that that tissue, that mucosa, thick and just not distending nicely, and the entire stomach did look a bit smaller, more kidney shaped than usual, didn't open up nicely at all. So this is Linitis plastica as well. Okay, what do you want to do here? Take a look. Sorry, you're in the stomach already and you're going towards the pylorus. This is the pylorus. This is just a routine scope that you're doing for dyspepsia. Okay, your options are to do nothing, to do a barium meal, to offer PPIs, or to diathermy through that mucosal band. What would you like to do? Okay, that's it. Yeah, do nothing, I agree. Diatherming through the mucosal band, I think that would just be for fun. I don't think there's any reason to do it. Yeah, I would do nothing. That's just a previous ulcer with a residual mucosal band. I wouldn't do anything. 29-year-old lady comes to you with an incomplete gastric outlet obstruction. I'm going to show you her duodenum, and then you can tell me what you think. So we're at Z line, and there's quite obviously an element of obstruction as you go through the stomach. There's the puddle of fluid there. There's your pylorus coming into view. That's quite a young lady, I forgot to mention. That's important. Okay, so there's quite obviously the cause for her gastric outlet obstructive symptoms. What do you think this could be? So either a duodenal cyst, an adenocarcinoma of the duodenum, lymphoma, or rather spectacular stage 4 Spiegelman FAP. So tell me what you think that might be. Okay, let's see, Cheryl. Yeah, lymphoma. So I think I would very much be concerned as regards either adeno or lymphoma. I find it difficult sometimes endoscopically to differentiate, and sometimes you just really can't. It's just a guess. I did tell you she's quite young. Yes, you get adenos at any age, obviously, but lymphoma of the duodenum is a very scarce thing. And when we do see it, it's invariably a younger person, unfortunately. So, yeah. So that was lymphoma. Then I'm going to show you an ulcer, and I've taken biopsies. I want to know what you think the pathologist told me. Okay, so we're in the antrum. And there's a giant ulcer of the distal lesser curve or above the incisura. I've biopsied that. I've done something which I don't normally do, and then I've biopsied a bit of the base of the ulcer as well. So what did it come back with? Chronic gastritis with ulceration, adenoceae, or normal liver tissue? What do you think? Okay, let's see. Yes, so this is an ulcer and has obviously perforated. It's an enzyme-induced ulcer, and it's gone. That often you see if they're sitting on the lesser curve, it'll go and stick and seal off on the belly of the left lobe of the liver, and then every now and then you biopsy that base, and you come back with normal liver tissue. So yes. Okay. When you see this specific ulcer, it's a new ulcer now, what are you going to ask your patient? Sorry?
Someone talking in between.
Okay.
Just a
Excuse me,
second.
somebody.
Can you mute yourself, please?
Carlos, can you mute? Carlos, can you mute?
Okay, I muted him.
Okay, cool. All right. So here's the last ulcer I want you to take a look at. And it is just beneath the OG junction. You can see it's quite a scary one, a nice juicy vessel looking up at you. My question is not what you're going to do about it. My question is, what are you going to ask this patient? Are you going to ask him, is he a smoker? Are you going to ask him, is he a recreational drug user? Are you going to ask him, did he have a recent alcoholic binge with severe vomiting? Okay, let's see. Yes, I don't know why, maybe somebody in the audience knows, but when you have someone who's taking a lot of tick or heroin or a combination, they often present with extremely high left lesser curvature ulcers, often just as you pop through the OG junction. I really don't know why, but it's often there. Yeah, looks like most of you agree. I don't know if somebody knows why. Okay, we're almost done. This lady is coming to you for her third scope. Both previously have been reported as normal. My question to you is, do you agree? Sorry if that was, there we go. So that's the esophagus. I'm not giving you any history because you should be able to see there's what the problem is on this. And there we are through. So, my simple question to start off is, do you agree that the scope is normal or not? answer very quickly. And Cheryl, what do you think? What do you see? Okay, good. So most of you said it's not normal. I agree. Those of you that said it's not normal, what is your provisional diagnosis pending further investigations? Severe volume reflux, achalasia, lower esophageal sphincter hypomotility. Okay, let's see. Yeah, thank you. If you go down an esophagus and you see puddles of saliva, but no obvious stricturing or anything distally, please, you must think of a dysmotility of the esophagus, and you have to look at either doing a swallow, barium swallow if you can, even better a manometry, but there is here definitely dilatation, hold up, puddling. I mean, this is an achalasia until proven otherwise. Good. Thank you. I think that is it.
That was the last
Thank you. Great. Thank you so much.
Elia, thanks very much. That is a real potpourri through the whole gambit of things that you might or might not see down in endoscope and what to do with them. There are a few questions in the chat box, and let me just have some of them. They relate backwards, but I think we can pick them up. Those pancreatic rests, do they ever get pancreatitis?
And not as far as I know of. No. I don't know if you disagree with that, Prof.
I don't think so. I don't think they have a ductal system, so I think it would be very unusual. And there's such a small volume that, yeah, you should just leave them alone.
Yeah, just stay cute. You must just admire them.
Yeah, indeed. Yes, the other thing about avoiding, there was a comment about avoiding bones, and that was to convert to being a vegetarian.
Point taken, yes.
Indeed. Yeah, and yeah, there was one thing that, you know, regarding these foreign bodies, especially, you know, some of these bones are not very obvious on plain X-ray. What's your advice to someone who persistently says they've swallowed it, or they've got a bit of difficulty swallowing, saliva, and pain well localized to the neck? What's your approach to them if you don't see it on a plain X-ray?
I think a plain X-ray is often quite a waste of time, to be honest. I wouldn't go by that. If you really are, you know, convinced there is something, first of all, you need to do a scope under proper sedation, so that you don't have a very mobile gagging patient, because they often stick just under the cricopharyngeus, and that's the area you tend to fly through when you do your scope. So it's nice to take a slow look through the cricopharyngeus and that very, very, very proximal esophagus when you're suspecting a foreign body. So that's the first thing, sedate the patient. If you want imaging, I think, you know, sure, you might consider a CT scan, a dedicated CT of the cervical region. I'm not sure, you know, a swallow is only going to help you if you're suspecting a perforation. I don't think it'll pick up very small, you know, like a snook bone, you're not potentially going to pick up. So I think an endoscopic slow examination under proper sedation is probably where I'd start off with. And often a rigid esophagoscopy is quite useful at the top, in that it sort of distends up and keeps that circumferential contraction, so to speak, of the cricopharyngeus open, and you get a really good view of that first centimeter below the cricopharyngeus. So that's probably where I'd start.
Yeah, it's interesting. I wouldn't think that many of the audience have experience with rigid esophagoscopy. It's not something that was traditionally in the hands of the thoracic surgeons. I must admit, I was involved in Victoria with a gentleman who was sent home and came back 10 days later, still complaining of dysphagia. And he had a visible bone. It actually turned out to be a chicken wishbone, but it was impacted, and it was impossible to remove it without a rigid scope. In fact, we had to go into the archives of the instrumentation at the hospital to be able to, at least someone knew where it was. But I was the only one who had an idea how to use it. Anyway, that's another story. But I think the question that was in the chat box is in relationship to using an overtube, to actually use an overtube to take it out. What do you think about that? Because we used to use that.
Yeah, I think definitely useful, especially if you've got a sharp, horrible, pokey kind of foreign body. Not, as you say, difficult to find. That would be something we'd also have to go and dig in the archives for. But yeah, for sure, that improves the safety of the removal considerably.
Does anybody have any other questions they'd like to unmute and ask Galia? I think we've covered most of the eventualities that you might see down in endoscope. I think there are a few that we all come across from time to time that cause us confusion. If you have, please put your hand up. We've got quite a fair smattering of people from all over the continent, and that's nice to see. If there's no further comments that I can see, I would just like to thank Galia for taking the time to revamp this talk, and as always makes it more interesting and more relevant each time she does it. And to thank all the participants for listening in, and to thank India for supporting us with the Indian Hub, and to remember that this is the proceedings today were recorded, and you can find them on the GastroFoundation website. It's a nice resource, and if there's anything you want to catch up on, that's a good place to visit. So thanks to everyone, presenters, and to the crowd once again, and hope to see you with gecko pathology next Wednesday. Have a good evening.
Thank you. Bye-bye.
Bye-bye.